Hello and welcome to a Health Podyssey. I'm your host, Alan Weil. According to UCSF Health, domestic violence is the most common health problem experienced by women during pregnancy. Estimates of violence during pregnancy are in the 4 to 8% range, with more than 300,000 pregnant people experiencing intimate partner violence each year. As such, access to abortion and the ability to terminate an unwanted pregnancy is related to the risk of experiencing intimate partner violence, which raises the question, is there a relationship between policies that restrict access to abortion and the incidence of intimate partner violence? That is the topic of today's episode of A Health Podyssey. I'm here with Maeve, Wallace, Associate Professor at the Tulane University School of Public Health and Tropical Medicine. Dr. Wallace and co-authors published a paper in the May 2024 issue of Health Affairs assessing the association between state laws that restrict access to abortion services and rates of intimate partner-related homicide. They found that rates of intimate partner-related homicide among reproductive age women increased in states following the enactment of restrictive laws. We'll discuss these findings in today's episode. Dr. Wallace, welcome to the program.
Hi there. Thank you so much for having me.
I am pleased to have you here to talk about this important and rather complicated subject for those who haven't focused on it as much as you have. Let's just start with some basic facts here. I said just a few in the introduction, but what do we know about the relationship between pregnancy and intimate partner violence?
Yeah, so just as you said in the introduction there, we know that pregnancy can be a really stressful situation, especially unplanned pregnancies and those that are happening in relationships that are already dealing with a lot of challenges. And so, as you mentioned, and as much research has shown, intimate partner violence can start during pregnancy, sort of as a result of the pregnancy, or it can escalate in severity during pregnancy. So it can really be a really dangerous time for some people. We also know that injuries inflicted on pregnant people are more likely to be fatal. So again, that escalation in severity and pregnancy itself being a really dangerous time. Research by our team and others consistently find that the rate of homicide among people who are pregnant or within a year postpartum are consistently higher than rates of homicide in women of reproductive age who are not pregnant or postpartum. This really demonstrates how pregnancy itself can be a risk factor or play a role in increasing someone's risk of experiencing intimate partner violence and fatal violence in the most extreme cases.
Before we move into your paper, I want to bring in the topic of unwanted pregnancy. You mentioned unplanned pregnancy, but do we know anything about the role of unwanted pregnancies when it comes to intimate partner violence?
Yes, we know that people who have experienced intimate partner violence during pregnancy report that the partners not wanting the pregnancy is one of the biggest predictors of violence occurring in that relationship. So it really can add a huge amount of stress and danger.
Okay, so you studied the effects of what in the paper you refer to as TRAPs, Targeted Regulations of Abortion Providers. These are laws that have been passed in states. Can you just say a little about what these laws do and why that's the way you measured restrictions on access?
So these laws dictate standards and regulations, guidelines that abortion providers and the facilities in which they work must adhere to. So, for example, having specific requirements around the size of the procedure room, the width of the corridor in the facility, requiring that the facility have a formal transfer agreement or that the individual provider has admitting privileges with local hospitals. And so, what's really important to note and underscore here is that these laws go beyond what is medically necessary to ensure patient safety. So these are not laws that are about making sure abortion is safe procedure and safe for people who seek it out, but really they're politically motivated attempts to restrict access to abortion. And they're really good at doing just that. To sort of answer your second question, certainly research has shown that TRAP laws, these kinds of laws, can result in clinics closing their doors, being forced to shut down if, for example, they can't afford to renovate to meet those structural requirements, or if they can't overcome the other barriers to meeting the transfer and admitting privileges, which again, there's no evidence that these requirements protect patient safety. So, a lot of this research came out of Texas, where we saw implementation of a series of trap laws, and what followed was forced closure of clinics in that state. And, as such a big state, people were already having to travel long distances to get to care. And after closure of clinics across the state, those travel times are now exponentially longer.
And I know we'll get into this as we move into focusing more directly on your paper, but these laws predate the Dobbs decision, even under the Roe v. Wade regime, if you will, where you had a guaranteed constitutional right to abortion. These were ways to restrict the provider side, not so much the patient side, right? To sort of make it harder to operate a facility where abortions could occur. Is that the right way to think about them?
Yeah, that's correct. These have been being implemented across states for, I guess, the past decade or more. Our paper went back to 2014, well before the Dobbs decision. And yeah, they were one of the most commonly enacted abortion laws and one of the most effective in terms of reducing access to abortion.
So we try to keep our methods discussions light on Health Podyssey because people who are interested in methods really do need to read the paper. But I'd like you to explain, if you could, how you explored the relationship between these laws and intimate partner violence-related homicide, which was the outcome that you were measuring.
Sure. So we used data from the National Violent Death Reporting System to identify all cases of intimate partner violence-related homicide and estimate annual state-level rates of that outcome among women and girls of reproductive age. And we were looking at the years 2014 through 2022. We also gathered annual state data on 5 specific trap laws. So the structural standards and those facility agreements that I mentioned previously. And so for each state, we counted up the number of laws that were in effect in each year. And we used difference in differences modeling just basically to compare states to themselves over time to see how do trends in the intimate partner violence homicide rate change in the state after changes in the number of trap laws that were in effect.
That was great. And again, those who want to go deeper should look at the paper. So what did you find? I think we ought to just start there. What's the result of the analysis?
Well, sadly, what we found was that for every additional trap law that went into effect, there was about a 3.4% increase on average in the intimate partner homicide rate experienced by women and girls in that state. We took that estimate and we extrapolated it out to the state's population to estimate about 24.3 instances of homicide that we can associate with the implementation of trap laws over the time period we studied.
Let's just talk about which population you were focused on here, because I do think that's an important part of the story.
Sure. So we looked at reproductive aged women. So this is broadly defined as age 10 through 44 in our study.
And I noted in the paper that some people might scratch their head at going down to age 10, but there was a reason for that. I wonder if you could explain.
Sadly, again, we find cases of pregnancy-associated homicide, so that's homicide of a pregnant person, as young as 13 in the National Violent Death Reporting System. We go down as far as 10 because the way that we defined intimate partner violence-related homicide involves people that are killed in the context of intimate partner violence. So in the case of a 10-year-old, this might be the child of a couple where intimate partner violence is occurring, and the child is the victim or one of many victims in those situations.
And how comfortable should we feel that we know when intimate partner violence is involved in a homicide?
I'm glad you asked that question because I always like to indicate that it's my belief, after having looked at these data for many years and being involved with a lot of this work on the ground, that we're underestimating the number of cases that involve intimate partner homicide. A lot of times there's just limited contextual information about these cases. And so, the goal is to talk to surviving family members, to talk to people that might know what was going on in this person's life. But sometimes that's not even known to close family members. And so the great thing about the National Violent Death Reporting System is that it tries to pull in data from multiple sources. So not only the death record, but more contextual information that can be provided from law enforcement reports or for coroner and medical examiner records to try and really piece together what happened. But I think more often than not, we would mark a case unknown when we don't know for sure that it was intimate partner violence related. And so I think a lot of those unknowns might in fact have had something to do with intimate partner conflict.
Well, I want to talk to you about how to make sense of these findings and what the implications are. We'll cover those topics after we take a short break. And we're back. I'm speaking with Dr. Maeve Wallace about the relationship between abortion laws that restrict access and intimate partner violence-related homicides. Before the break, we learned the findings that there is a relationship that's demonstrable in the data that after states pass these laws, there are increases in intimate partner violence-related homicides. So one of the things we always want to do trying to understand research is to not just sort of look at the numbers, but to understand a logical pathway. Data can show you, or statistics can find results that maybe don't make sense, and then it's just sort of a data artifact. In this instance, I think it would be helpful if you sort of played out the scenario here of what is happening that could cause these results, acknowledging that that's what's happening is not what you studied in the paper. The existence of it is what you studied in the paper, but your work occurs in a context, and I'd like to get a better sense of that.
As we talked about in the opening, pregnancy is a dangerous situation for some people, and it can increase the chance that you experience fatal violence at the hands of the person involved in pregnancy, so their intimate partner. So, it sort of logically follows then that a person's ability to control whether or not they become pregnant or to end a pregnancy, should it happen, it may be really important, and in a really important way that they keep themselves safe. We know from really rich qualitative research, we're listening to people who've gone through this, gathering lived experience narratives, or even just, talking to people who work in the domestic violence advocacy field who have sort of known that this mechanism exists and live it every day, that, ending an abusive relationship or avoiding bringing children into a violent relationship are common reasons why people might seek out an abortion. In a situation where abortion is difficult to access because it's no longer legal or because it requires a long distance to travel or to get to a facility that can provide care, it then becomes inaccessible to people who don't have the money or other resources, thinking about time off work, childcare, transportation, all that you might need to get to that care. And so those might be the same people who are experiencing violence in the home, trying to, not put themselves and any other children at risk of this violence. And so those are the ones that are most in need of the options to protect themselves.
Now, as we noted earlier, your study looks at data before the Dobbs decision that overturned Roe v. Wade. I suspect our listeners have a general understanding of this, but I think it would be incomplete to have this conversation without drawing a link between the time you studied and where we are today. So can you say a little bit about what's happened to access to abortion in the time since that decision?
Yes, and I think, as you said, and I hope all of our listeners are sort of aware of what happened to abortion access in the post-Dobbs period. But with the Dobbs decision, abortion is no longer a federal constitutionally protected right. And currently we have 14 states where abortion is illegal, so banned outright. And we have many other states that continue to highly restrict access to abortion with trap laws like those we studied here, with narrow gestational limits, and with other, similar regulations on both the provider and the patient side. Safe to say access to abortion has declined in the post-Dobbs period.
Indeed. And again, your study focused really on provider side restrictions. But of course, in a post-Dobbs era, you can now directly legislate on sort of the patient side, if you will. You mentioned that you can't have a conversation without this topic without acknowledging that the politics of trap laws, these are legislative actions, and legislators take lots of things into consideration when they vote on a bill. And certainly their views about abortion play a role in what restrictions or limitations they're willing to support. So my question to you is, how would you go to a policymaker who's trying to consider laws that might restrict access to abortion and present these findings in a way that might affect or help them think about the implications of their actions.
Oh, well, if I knew how to do that, I would be doing it every day.
Well, you can try it out here.
Sure. And yes, I mean, it would be wonderful if policymakers would incorporate scientific research evidence into legislative decisions. I don't see that happening, but we continue to, put the evidence out there. So, what I hope that this evidence and other studies like it can do is sort of broaden policymakers' understandings and view of the implications of restricted access to abortion. So they might have an opinion about it based on what they believe, but really understanding the broadness of what can occur in the absence of legal access to abortion. So the importance of ensuring women are able to exercise bodily autonomy, especially when it means life or death for them, as in the case of homicide in our study. There's research evidence out there showing that restricted access to abortion may increase maternal mortality from obstetric death, maternal suicide, maternal homicide in our work, infant mortality, so that's death of a live-born baby before their first birthday, and all of these horrible outcomes that I think surely even policymakers would do everything in their power to prevent. That's my hope, is that we can just keep producing and expanding the evidence on the harms of this context until it's acted upon in a way that just ensures everybody has the right to be safe and to live a healthy, productive life.
Well, one of the things I took away from this is also the really limited scope of the phrase that often rolls off the tongue in abortion discussions: exceptions in case of rape, incest, or the life of the mother, which has become sort of a shorthand for the kinds of situations that even those who generally oppose abortion understand that there should be exceptions to that opposition. And although we don't need to get into sort of the deep politics of whether or not those exceptions are, how meaningful they are, whether they distract from the vast majority of abortions that are not related to those things. But what I do feel your study does is it provides some nuance, because my sense would be that the vast majority of homicides that you describe and studied in this work are not situations that would have fallen into one of those exceptions, and yet they led to the death of the mother or the pregnant person. And that seems to me to be an opening for changing the discussion and acknowledging that those narrow exceptions, they're not just narrow, but they're sort of grossly incomplete. I don't know. Maybe again, I'm not suggesting that, again, policymakers change their point of view on the basis of a simple, persuasive paper, but it does seem to me to point to dimensions of the risks of pregnancy that are often overlooked. Does that give you any hope?
100%. I completely agree. And that's certainly a case that I've tried to make before. That's just it, the life of the mother. And when you think really about what are among the leading causes of death of pregnant and new moms, postpartum people, it's, homicide, suicide, drug overdose. These are things that are leading causes of death in pregnancy and may be directly preventable if the pregnancy had not occurred itself. And so when we think about making exceptions, I don't even like the language around exceptions. But I agree with you 100%. And I think, again, to broaden our view of the implications of not being allowed to exercise the right to bodily autonomy, of course, you run the risk of a dangerous pregnancy and a high-risk pregnancy situation in which you can't even receive the appropriate care, which we're also seeing happening now in the post-op period because of providers being afraid of legal consequences for treating miscarriage, for example. But thinking, yes, about all of those other ways that people are dying during pregnancy and postpartum that are 100% avoidable and preventable.
Well, Dr. Wallace, thank you so much for doing this important work and the conversation, explaining the approach you took and the findings you had. Thank you for being my guest today on Health Podyssey.
Thank you so much for having me.
Thanks for listening. If you enjoyed today's episode, I hope you'll tell a friend about Health Podyssey.